Welcome back to the Deep Dive. Today we are staring down a deadline. And I don't mean the kind where you can just, email your boss, fake a cough, and ask for an extension over the weekend.
No, this is a bit more serious than that. When you put it that way, it sounds ominous.
It kind of is. We're looking at a global hard stop deadline that is fast approaching, 2030.
And in the world of global policy, 2030 is basically tomorrow morning.
It really is. We're talking about the United Nations Sustainable Development Goal number 3, SDG 3.
Right.
The premise on paper is, beautifully simple. Ensure healthy lives and well-being for all by 2030.
All is doing a lot of heavy lifting in that sentence.
It really is. Because when you peel back the layers of what all actually means and you look at the logistics, the scale is just mind-bending.
Yeah, we're not just talking about improving wait times in London or New York. We're talking about universal health coverage for the most remote, infrastructure-poor regions on the entire planet.
Exactly. And to guide us through this, we're unpacking a stack of materials around the work of Dr. Padmavati Roy. We've got her research, some blog posts, video scripts, and specifically her analysis of a platform called the Times Health app. But before we get to the tech, and the tech is fascinating, I want to talk about the problem, because Dr. Roy's work, it challenged a lot of my own assumptions.
Oh, yeah. In what way?
Well, when I think of global health crises in developing nations, my brain immediately goes to a very specific script. I think of the big, loud, infectious outbreaks.
Like malaria, HIV/AIDS?
Exactly. Malaria, AIDS, Ebola. I think of these acute battles, people in hazmat suits, emergency tents.
The Hollywood version of global health, in a way. And look, to be clear, those battles are absolutely real and they're still being fought every single day.
Of course.
But what Dr. Roy's research highlights is that while we've been fixated on those, let's call them loud epidemics, a silent crisis has been creeping up behind us.
A silent crisis.
Yeah, it's a huge shift in the epidemiological landscape that most people just aren't talking about.
And that shift is the explosion of non-communicable diseases, or NCDs.
Right. We're talking about things like type 2 diabetes, hypertension, cardiovascular disease, obesity.
Things we used to call diseases of affluence.
We did. We assumed they were problems for the wealthy West, too much fast food, sitting in office chairs all day. But the data shows that's just not true anymore. These diseases are exploding in developing nations.
And that's the part that feels like such a cruel twist. You have populations still dealing with malnutrition, and now you have a diabetes epidemic on top of it. But here's the key insight from the sources that really stuck with me. The nature of these diseases breaks the healthcare model.
Precisely. This is the structural mismatch. Most healthcare systems in the developing world were built for infection control.
Right.
If you have malaria, you get diagnosed, you take the meds, the fever breaks, and you go home. It's transactional. It has a clear beginning, a middle, and an end.
A one-and-done interaction. You see the doctor, get the shot, you're good.
Exactly. But NCDs, diabetes is a life sentence of management. You don't cure hypertension, you manage it for decades.
It requires constant monitoring, blood work, diet changes.
Consistent medication for 30, 40 years. It's a relationship with the healthcare system, not a single transaction.
And that requires a doctor you can see more than once in a blue moon.
And that is where the system completely collapses. You can't manage a chronic condition if you can't even get to a doctor.
So that brings us to the central question of this deep dive.
Yeah.
How you solve a healthcare crisis that demands more contact time when there literally aren't enough doctors to go around.
Okay, so let's get into the numbers. Because not enough doctors is an abstraction until you see the actual data.
It really is. Dr. Roy's notes lay out this geography of inequality in a way that is, frankly, it's terrifying. I want you to visualize a crowded room.
Okay, let's set a baseline.
If you're in a developed nation, let's use the example from the text, Austria. In Austria, there is one doctor for every 182 people.
Wow. That's a very tight ratio. Access is basically assumed at that point.
Right. You might have to wait an hour, read an old magazine, but you will be seen.
For context, the OECD average, so the Wealthy Nations Club, is about 3.56 doctors per 1,000 people. So the West is, relatively speaking, swimming in care. The system assumes a professional is available.
Okay, now let's travel. Let's go to Bangladesh.
Okay.
The ratio drops to 0.39 doctors per 1,000 people.
So we've gone from, what, one doctor for a small neighborhood to one doctor for a stadium.
But wait, it gets worse. Dr. Roy's research zooms in on India And this is where the disparity becomes just heartbreaking.
Mm-hmm.
The national average in India is one doctor for every 1,445 people. That's already incredibly strained.
But averages lie. That's the thing, because doctors, like most people, they cluster in cities where the money and the resources are.
It's the urban bias. It happens everywhere, but in developing nations, the gap is a chasm.
A chasm, yeah.
But what happens when you leave Mumbai or Delhi and you go into the rural areas, the ratio it plummets.
Yeah.
To one doctor for every 11,082 people.
1 for 11,000.
11,000.
You have to pause on that. That's not a healthcare system. That's a lottery.
It's impossible math. If you're that one doctor, you're responsible for the health of a whole town by yourself.
You can't do it. You physically cannot see that many people, let alone provide that chronic long-term management we just talked about for diabetes.
If you spent just 5 minutes with each patient, it would take months to see everyone just once.
And for the patient, this ratio translates into real physical barriers. The sources describe scenes they're just difficult to read.
Yeah.
Dr. Roy mentions communities where emergency transport is literally neighbors carrying a pregnant woman in a bedsheet to a center that's miles away.
That image, carrying someone in a bedsheet in 2025 while we have billionaires taking joyrides to space.
Yeah.
It just highlights the total collapse of infrastructure.
It does, and you see these heroic attempts to fix it that actually just prove why the old model fails, like the Felifepa train in South Africa.
The train of hope.
Right. It's a literal hospital on wheels. It travels the country, rolling into underserved areas, providing mobile clinics.
It's incredible work.
It is. It saves lives. But think about the implication. If you have to wait for a train to roll into your town to get your eyes checked, that's not a sustainable system.
What happens if your blood sugar spikes the week after the train leaves?
Exactly. It's a stopgap. It proves we can't build brick-and-mortar clinics fast enough. We can't train human doctors fast enough to hit that 2030 deadline.
Medical school takes 10 years. We've got 5 left.
So if we rely on physical atoms, buildings, roads, trains, human bodies, we lose. We lose this fight.
Okay, so if the physical infrastructure is too slow, too expensive, we have to go digital. This is where we pivot to the solution, the digital bridge.
Telehealth.
Right. Now, I can hear some listeners rolling their eyes. We all lived through the pandemic. We know what telehealth is. I sit on my couch, FaceTime my doctor. They tell me to drink some fluids.
It's convenient.
It's convenient, sure.
Yeah.
But how does that solve the one doctor for 11,000 patients problem? If that one rural doctor just gets a webcam, doesn't he just have 11,000 Zoom calls to make? He's still overwhelmed.
That is Telehealth 1.0. You've hit it exactly. It works when you have a 1 to 182 ratio, like Austria. It's a convenience layer. But in the Global South, you need Telehealth 2.0. You need a force multiplier. You can't just digitize the same broken workflow.
So let's break down what this 2.0 model actually looks like. The sources point to 3 pillars: mobile connectivity, remote diagnostics, and the big one, AI integration.
Let's start with connectivity. Even in places with no paved roads, no running water, you will often find a cell signal.
Right.
The spread of mobile networks is one of the great untold stories of the last decade. People who don't have toilets often have smartphones.
So the strategy is to bypass the mud roads and just use the airwaves.
Exactly. You don't need a highway to send medical data. But then you hit that same bottleneck, the doctor shortage. You have the connection, but who's on the other end?
Right.
And this is where AI comes in, not as a robot doctor, but as what the sources call a burnout shield.
A burnout shield. I love that phrasing. Explain how that works.
Okay, think about a normal doctor's visit. So much time is just spent on intake. What's your name? What are your symptoms? How long has this been going on? Let me check your history.
The administrative stuff.
All of it. And if a human doctor has to do that for 11,000 people, the system crashes. They spend all day typing, not treating. It's system overload, like the text says. But if you integrate AI, the platform handles that front-end work. The patient interacts with the app first. The AI gathers symptoms, analyzes initial data, maybe even captures vitals from a connected sensor, and it synthesizes all of that into a prioritized packet for the doctor.
So it's like a super efficient triage nurse?
Precisely. It filters the noise. It means that when the human doctor finally looks at the screen, they're not starting from zero. They're looking at a curated summary that says, this patient has these symptoms, these vitals are abnormal, here is the likely issue.
So it lets them make a high-level decision diagnosis and treatment in a fraction of the time.
It preserves the human capacity for the things only a human can do. The empathy, the judgment call, the complex treatment plan.
It allows that one doctor to manage a population that would otherwise just completely crush them.
It's the only way to make the math of 1 to 11,000 even begin to work. Instead of seeing 20 patients a day, maybe they can effectively manage 100 cases because the AI is doing the heavy lifting.
It's fascinating because usually when we talk about AI, the narrative is all fear. AI is coming for your job.
Right, AI is going to replace the radiologist.
Exactly. But here, the argument is the complete opposite. The AI isn't replacing the doctor. It's the only thing keeping the doctor in the game.
It turns AI from a threat into a lifeline. In a resource-starved environment, efficiency isn't about profit. It's about survival.
Okay, so we have the theory. We have the digital bridge. But theory is cheap. Let's look at this in the real world. Dr. Roy's research points us to a specific case study trying this right now, the Telehealth app.
This is a really compelling story. It blends this high-tech solution with a very specific kind of philanthropy.
The visionaries are Dr. Mathew and Guru Kora.
Right. And their background is so important to the model. They're U.S.-based. They've had successful careers in the West in medicine and tech, but they are a part of the Indian diaspora.
And they're looking back at their country of origin and seeing this crisis. And the sources really highlight this isn't a typical Silicon Valley startup play. They're not trying to build a unicorn to sell to a VC firm. They're not targeting the wealthy elites in Mumbai who can already get great care.
That's the key distinction. Most health tech follows the money. It builds features for the worried well in rich cities' apps to track your steps or help you meditate.
Which is fine.
It's fine, but it doesn't solve SDG 3. The Telehealth app is explicitly targeting that 1 in 11,000 demographic in rural areas, and it's designed to be freely available.
This connects to that idea of diaspora and global philanthropy from the notes. It feels like a replicable framework.
It is. You have this massive reservoir of talent and capital in diaspora communities, doctors, engineers, entrepreneurs living in the US, the UK, Canada. They have access to the best tech in the world. And people like Dr. Mathew and Guru Kora are essentially building a pipeline to funnel that technology back to where it's needed most. It's a form of brain gain, not brain drain.
So the app provides free, remote consultations and that AI-driven support. It puts the burnout shield directly into the hands of rural healthcare workers.
And by making it free, you remove that huge economic barrier. If a patient has to choose between buying insulin and buying food for their family, they're going to buy food.
Of course.
If the consultation is free and the management is streamlined, they have a fighting chance.
So I'm thinking about the scale of this. We've talked a lot about India because that's the test case for the Telehealth app. But is this just an India story?
No, not at all. And that's really the so what for everyone listening globally. Dr. Roy specifically notes that this is a replicable model.
Because the math, the low doctor ratios, that's not unique to India.
Not at all. Go back to that Bangladesh stat we mentioned. Look at sub-Saharan Africa, parts of South America. The twin problems of the NCD silent crisis and the lack of medical professionals. That's universal in the global south.
So if you can crack the code in rural India, if you can prove this AI-assisted, diaspora-funded model works in a village with spotty internet and 11,000 patients,
you have a blueprint for the world.
You don't have to reinvent the wheel for Kenya or Peru.
Exactly. You take the digital bridge architecture and you adapt it. It shifts the entire global health strategy from build more hospitals to optimize the connection. It lets these countries leapfrog a whole phase of development.
Just like they skipped landlines and went straight to mobile phones.
They might skip the big central hospital model and go straight to distributed digital care.
That's incredibly hopeful. It makes that 2030 deadline feel, well, slightly less impossible. It feels like we actually have a map.
It gives us a fighting chance. It changes the variables from impossible to hard but doable.
Now, for our listeners who are really digging into this, maybe you're a developer or you work in public health or you're just a logistics nerd like I am.
And you want the nuts and bolts, the technical execution.
Right. How do you handle patient data privacy in a rural village? How do you deal with 3G versus 5G? How do you train an AI on local dialects? There's some upcoming coverage we need to flag here.
Yes, this deep dive is really just the primer. Dr. Padmavati Roy, whose research has guided us today, has her own platform, EMST Podcasts.
And according to the source material, she has a major interview lined up.
In early July 2025, she is sitting down with the founders we just mentioned, Dr. George Mathew and Guru Kora.
That's going to be the deep, deep dive.
Absolutely. The notes indicate they're going to get into the technical how-to, but also that replicability question. How do you navigate regulations in different countries? How do you sustain a philanthropic model? If you're interested in tech, ethics, and global health, that's where the rubber meets the road.
Okay, so mark your calendars for July 2025 for that. But before we wrap up, I just want to circle back to where we started.
The deadline.
2030. We started with this terrifying Stat 1 doctor for 11,000 people. We looked at the rise of diabetes, a disease that needs constant vigilance.
And we saw the old ways, carrying neighbors in sheets, waiting for a hospital train. They're symptoms of a system that's just been completely overwhelmed.
It feels like we are at a crossroads.
Mm-hmm.
On one side is the collapse of the system. On the other, we have this high-tech solution.
It shows that technology is no longer a luxury in global health. It is the infrastructure. You can't pave the roads fast enough, but you can beam the data.
I want to leave you, our listener, with a thought to chew on. We talk a lot about the risks of AI. We worry about deepfakes, about algorithms, about automation taking our jobs. And those are all valid worries.
AI replacement anxiety, yeah, it's real.
It is. But in the context of global health equity, I want you to just flip that script. What if, instead of asking, will AI take my job, we asked, can AI save this system?
That's a powerful reframing.
I mean, think about it. In a world where a doctor has 11,000 patients, AI isn't a competitor. It's an exoskeleton.
It's a lifeline.
It might be the only thing keeping that doctor from burning out and the only thing keeping those patients connected to a diagnosis that could save their life.
It transforms tech for good from a marketing slogan into a literal survival strategy for millions of people.
It's not just code. It's the difference between being treated and being forgotten.
Couldn't have said it better myself.
That's it for this deep dive. Go check out the sources. Keep an eye out for that interview on EMST podcasts in July, and we will see you next time.
Stay curious.